Um, so, one of the things I could sit here for 45 minutes and try to talk to you about Pete sports, but it's just not worthwhile to just talk about that and all these surgical techniques. You guys will get that on the rotation. So I felt, kind of in the name of kind of diversity and disparities, I wanted to give you a talk kind of a little bit about identifying and reducing care disparities in sports medicine. I think it's a topic that we don't talk about a lot, and I think that potentially in 45 minutes you'll get more take home from this than learning where you drill your tunnels for pediatric ACL. And there will be obviously a large component of this. We'll look at disparities in terms of pediatric sports, and I think this is kind of a little bit more of a high yield topic for you, particularly as you go into practice, and kind of bridges a lot of the diversity work we're doing with kind of how it affects disparities at the at the sports medicine level. So feel free to chime in, ask questions as I go along, but we'll go ahead and get started. Okay. So I think, the purpose of this talk, number one, it's important to understand the definitions. I know all of you have been getting a lot of talks in terms of, diversity, equity, inclusion, but sometimes it's hard to kind of get a grasp of some of the definitions. Then it's important to get a sense of what's going on in orthopedic surgery globally. And then particularly, let's look at sports medicine as well, too, because I think we understand how it impacts older patients in terms of arthroplasty and other things like that. But I think in sports, a lot of the disparities are highlighted because it's a selective practice. It impacts the ability to participate in kind of athletic activity, and it affects pediatric patients particularly as well too. So we'll kind of go into detail about that. So I think the most important thing for us is you have to understand the terminology, and then as individuals, residents, as much as I would like you to learn the surgical techniques, et cetera, if you're able to look, when you go out into practice, whether you be in an academic institution or at a private practice, if you can look at your practice and then affect change in terms of what patients are coming in and eliminating disparities, that's just as important as being a surgeon who can do an ACL in 60 minutes as opposed to 75 minutes. Okay. A couple of us, Lionel, Derek, Rosie, and I did this article. Actually, now it's been 3-4 years ago, where we looked at concepts in orthopedic care disparities, and a lot of the feedback we got when we did it, it's like, yeah, we all know this. There's tons of articles that talk about, how there are all these disparities, but the problem is that we don't really take the next level. We know that patients do worse based on race, socioeconomic status, et cetera, and we talk about it, but then what can you do tangibly to actually make a change? Because if we just kind of have all this data out where we're like looking at, oh, there's disparities in X, Y, and Z, but then you don't do anything about it, it's just publishing to get another paper in PubMed. So I think it's important to critically look at how can you, even at a resident level right now, impact change, particularly from a sports medicine perspective. So like I said, it seems obvious, but it's not necessarily in the way that you think. And when you think about delivery of healthcare, it's affected in multiple different ways. And a lot of us do concentrate on race and ethnicity. We don't necessarily think about gender as much, too. We think about gender from a perspective of who is actually being trained in orthopedic surgery and sports medicine, but not necessarily how that impacts care. We very rarely ever talk about sexual orientation and socioeconomic status. We have a tendency to lump together with race and ethnicity, but we shouldn't necessarily be doing that. And I think in California, a lot of you, know that when you're seeing patients who may live up in Humboldt County or live 5-6 hours away, that's not necessarily tied to their race or ethnicity. It's due to the fact that they're in a resource poor area. And for someone who comes from 7 hours away and doesn't have access to a sports medicine surgeon or pediatric orthopedic specialist, the way they interact with the healthcare system is going to be much different than potentially a patient who's African American who lives in San Francisco or Oakland. So I think you also have to look at it in terms of a resource allocation standpoint. And when you think of it from a sports medicine or peds ortho perspective, if a patient comes in, you're like, yeah, we're going to do your ACL, and then you never think about where they're going to do their PT. You never think about, who's going to be checking their wound if they're going to be able to come down. It's probably better to get that stuff figured out on the front end rather than have them, we all too often say, well, they retore their ACL because they never got into PT. Well, that's your fault because you never helped set them up with it. So I think it's important to address those things from the beginning rather than just simply blaming it on the patient. And that's where a lot of the disparities exist. So we just have a tendency to blame people for circumstances that are not in their control, but we can affect in the healthcare system. So, when I ask people, what are the specific ways you can make an impact? And I think it's first important to recognize that it's important for us as physicians to know it impacts healthcare outcomes as much as the interventions we do, particularly from a pediatrics perspective where, kids heal. Okay. So we do an ACL, they're going to heal. You do your meniscus, they're going to heal. You're going to pin their elbow, they're going to heal. But actually what may impact them more are these disparities, how quickly they get to us, how quickly they get their ACL done, how much PT they get. So it's important to know that we concentrate on technique, outcome, research paper, but it's those other things that by the time they come into the door that'll impact their care as much as what we do. And it's also important to kind of understand how disparity impacts them. So it impacts the health of the individual and the healthcare of the individual. And those are two kind of distinct things. If you look at health of the individual, it's a higher burden of disability of one group compared to another. When you think about the healthcare of the individual, it's difference in access to care or quality of care that can't be explained by other factors. It's important to understand that. And not surprisingly, when you look at orthopedic surgeons, we do horribly. We all think it's not our problem, but it's other people's problem. And there are multiple studies that have shown this, that basically say, look, it's not my practice, it's other people's practice. Maybe we need to educate people more, et cetera, et cetera. But then we just move on with our day and don't actually address it. And if we actually look at more data, I think a lot of this has to do with who we're training. And now UCSF does a great job of, trying to attract a diverse group of residents and faculty. But if you actually look at the numbers and you see this graphic right here, it's pretty striking. I mean, see, pediatrics is very gender diverse, and you see us down at the bottom over here. So we're definitely not representative of other specialties, even other surgical subspecialties as well too. So that's where one aspect where we can kind of make change is who we're training. If you also look at this data based on race, once again, every year, even 10 to 15 years ago, we haven't changed the numbers as much. Underrepresented minorities make up about 2 to 3% of the orthopedic workforce, and even residents right now, it's still the same spectrum. So we're still doing a really poor job, even though at UC I assume we're doing very great. Other programs across the country aren't doing a good job, and it's not just necessarily at the program level; it's also what do we do at the lower level? So whether it's at the high school level, the undergrad level, the medical school level, how do we get people who are in certain communities interested in sports medicine or orthopedics? And that may not necessarily be a surgeon. It may be a physical therapist. It may be an athletic trainer, maybe a coach, maybe someone who is in sports journalism. There are different ways you can get involved in sports that aren't necessarily that area. And we need to be examples of that, even though we may be spending a lot of our time doing orthopedic surgery. So if you look at overall orthopedic literature, we know that race and ethnicity leads to poor outcomes, particularly in certain areas. And there's been a lot of literature in terms of spine and arthroplasty for that. It's also important to note that race impacts the type of insurance that you get. So we have a tendency to tie race and socioeconomic status, but also race impacts the ability to gain insurance. And you can see, obviously, African American and Latino patients are less likely to get insurance, and insurance is intimately tied in the ability to access the healthcare system, particularly in something like sports medicine, which is so dependent on physical therapy and all these ancillary services as well too. Race also impacts access. So even though once you get care, your outcomes may be worse. Even when even the ability to basically access healthcare system is impacted as well too, as is immigration status as well too. So just like we don't talk about gender as well too, we don't talk about immigration status. A lot of patients will get their surgery, never want to come back because they have a fear if they're undocumented of getting reported or accessing care for things like that. So these are all the factors you need to be thinking about when you're determining care, not just necessarily whether you're going to operate or not. And a lot of this has to do with perceptions of the healthcare system. If you're an African American patient, or you're a Latino patient, or you're female gender, or you come from a certain, a rural area, your perception of when you walk in this office is definitely going to impact your care. And so when a patient comes in and is being very belligerent or is upset with you, it's important to take a step back and wonder why is this happening? What's their preconceived notion when they come in? And then you can deliver more effective care, as opposed to simply just saying that patient's crazy, and then you're just less willing to take those extra steps to help them. So the reason why this occurs, we've had multiple talks on implicit bias. As providers, we all have implicit bias, and you can all define that. But how that necessarily then impacts care, if you think at a microscopic level, think of a meniscus tear, okay? So if a 35-year-old comes in with a meniscus tear, and you have a preconceived notion about whether they're going to do PT, where that tear may came from, if they're going to be compliant, are you going to be more willing to prescribe physical therapy for them? Are you going to give them injection? If someone comes in, from Pacific Heights and has a meniscus tear, are you going to be like, oh, I'm going to repair that and really do a great job of repairing it because you're going to get back to activity? So I think we have a tendency to think of activity level, or is this a high level athlete, or are they going to be playing sports? And that determines what care you're going to give them. When in essence, you should simply just be looking at the MRI and being like, based on this meniscus tear, it doesn't meet criteria for me to repair them in the context of their activity level. And that's how at the microscopic level, particularly in sports medicine, where there's a lot of nuances in terms of how you deliver care, or even for a pediatric patient in terms of how you deliver care, where implicit bias can play a role, and then impact the downstream care. So what are things that we can do, okay, before we kind of dive into the sports medicine and peds? I think number one, you have to understand access to care. You have to understand quality and outcome of care, and then promote provider diversity. So when you first start with understanding access to care, okay, we know that there's tons of primary care literature. There are multiple mechanisms in place for people to be able to access a primary care physician, right? So you've got your hospital system, you have your emergency room, you have your primary care clinics. There are multiple ways that patients can access them. But then you ask someone how you can actually get in to see a subspecialist, and it's extremely difficult. Do they need a referral? Do they not need a referral? Is there a community clinic? Do they have to go to, an SFGH or a Highland? And it becomes very, very difficult, even for someone who has private insurance, to access that care. So a lot of times what happens if you just don't have those means, you have a meniscus tear, you have a rotator cuff tear, you have an OCD in a kid, and you just never get access to care for it because you don't know, you just never get that care because you don't know how to access the system. So we do a poor job of doing that. And orthopedics is a prime example. If you ask people who treats sports medicine injuries or who takes care of pediatric patients, they don't know. So are we even doing a good job of informing our ERs, our primary care providers, where they need to go to access care? Insurance status plays a role too. Scheduling is more complex for publicly insured patients. And then from a provider level, there's large variations in reimbursement. So when you're in an academic institution, we get reimbursed very well, regardless of whether it's a private or publicly insured patient. But if you go out into private practice, or if you go into rural areas where you'd assume that, there's this one hospital within a 3-hour radius, and they may be like, look, I'm not going to get, reimbursed very well for this. They have to go 7 hours to the city to get their care. So who accepts public plans and not is really important in terms of how care is accessed. And then treatment delays lead to poor outcomes. So we've shown this in terms of rotator cuff. We've seen this in terms of hand flexor tendon issues. We've seen it in terms of arthroplasty. And the same thing holds true with race. The ability to access the healthcare system and what treatments are actually offered to patients based on their race, as well as their socioeconomic status. And then how patients interact with you is based on those perceptions as well, too. So I think it's important to understand these layers and how they impact your outcomes besides just those kind of stringent factors that we talk about in post-operative conference, how the x-rays look, where your tunnels are, whether you should have fixed it or not. There are a lot of other factors that go into outcomes that we just don't report in the literature, which is important to consider as well too. And then gender as well too also impacts care, and we don't think about that as well too, particularly in a sports medicine practice. Who is offered access to rotator cuff surgery? Who's offered access to arthroplasties based on gender as well too? Because unfortunately, as we know, sports, orthopedics and sports medicine is a very male-dominated field. So for a lot of surgeons, they'll say, "Oh, this female patient may not necessarily be involved in a lot of strenuous physical activity." They have these biases in terms of what they're basically going to prescribe treatment. So a lot of times, females are prescribed drastically different treatments than males are in a sports medicine setting due to providers' preconceived notion as to what their activity level will be or how vigorous activity they're being involved in. So once again, we don't report that. So when you look at a paper that may look at outcomes after meniscus surgery, you have to look at what was the gender breakdown, what were the treatments given in terms of female versus male, African American versus Latino versus white, and then you can get a better sense of, okay, why are these outcomes the way that they're reporting that they are? And arthroplasty and spine have done a great job of that, but sports medicine and peds are still kind of at the cusp of reporting that literature a little bit better. And then you have to understand how it impacts quality and outcomes of care. And I think this is where we've had tons of research out there. You all know that based on race, socioeconomic status, et cetera, we have poor outcomes if you're part of certain groups. And this isn't all over the literature, and you guys can all identify that. So I think that's, we know that, but then it's that next step of why does it occur and how can we change it? Okay. And this is all hip fractures, et cetera, all show this problem. And I think in sports medicine, we have this problem as well, too, and it's not as reported as much. Arthroplasty does a great job, spine does a great job, but it definitely does impact the sports medicine community as well, too, particularly when you look at data in terms of ACL, meniscus, rotator cuff, and shoulder instability. And actually, interestingly enough, you would think that perhaps that would impact the adult population, but most of the disparities actually in the literature have been shown in the pediatric population. And I think the reason why that's important is that when you think of a pediatric athlete and a pediatric sports medicine patient, and we've seen this a lot during COVID, is that the lack of access to sporting activity dramatically impacts mental health. It impacts school performance. And then if you look at a health system perspective, if you have a kid who can't get access for a sports injury at a young age or has kind of inferior access than someone else, that's going to impact their health as an adult. So if you have an ACL tear at age 12, you can't get in, you have an irreparable meniscus tear, and then you're not able to actually access care, then you're not going to be active as a 20, 25, 30-year-old. Then you're going to have higher rates of cardiovascular disease, of diabetes, et cetera. Your mental health isn't going to be as appropriate if you're not working out. So I think it's important to address these issues in pediatrics, particularly since at baseline, the re-tear rate already is so high. They're more likely to fail these surgeries. And then subsequently you throw in race, socioeconomic status, et cetera, access to care. And then you basically have this whole population of kids who aren't getting appropriate care. And there are a lot of factors that we can correct. So we don't have those problems when they're 30, 35, and 40. I should have put an Achilles picture in here as well too. So this is it's a sad picture, but we'll talk about ACL tears. So if you look at most of the literature in terms of delays in care, there's most of it is in pediatric ACL. So there's a study that was done out of CHLA where they basically looked at socioeconomic factors, particularly looking at insurance, and they found that publicly insured pediatric ACL patients were more likely to have treatment delays, and these are significant treatment delays, several months. They're more likely, therefore, were then to have meniscus injuries because if you have a ACL injury, particularly in a pediatric patient, we know that if you don't treat them, and this is why we've started treating younger and younger patients, is that we know that delays in care will lead to more irreparable meniscus tears. Now, this is a little bit different than the adult population. If you already have some pre-existing arthritis, you can potentially then, delay or not even get your ACL done. But for a 12, 13, or 14-year-old, you tell them, don't get your ACL fixed or wait till you're mature, or you know what, it's going to be 5 months before we get you in for your surgery. They're going to have irreparable meniscus tears, and then have arthritis. And then even after you operate on them, and this is the issue, this is the example of the rural patient, if they don't have as much physical therapy, they're more likely to get stiff and have poor outcomes. So it impacts them at multiple different levels. This was another study that was done in Colorado, and you can think, LA, one population, Colorado, completely different population. Even in Colorado, we found that publicly insured patients or patients with lower socioeconomic status had about a 2-month more treatment delay, and that's pretty significant for an ACL tear. If you have a kid who's probably going to feel pretty good in a couple weeks after they've torn their ACL, and then they're subsequently going to be like, well, look, why do I even need to get this done? They get the treatment delay, then they're getting that bucket handle meniscus tear by going back to sports simply because they didn't get back in for their ACL tear. And then you look at Philadelphia. So we basically got LA, we've got Colorado, and then we go all the way out to the East Coast into Philadelphia. And they looked at their pediatric patients as well, too. And they found that Black, Hispanic, and publicly insured patients had treatment delays. They had more severe meniscus tears at the time of surgery. They had less PT visits, and they had greater residual hamstring and quad weakness. So you can see how at every different level, whether it's getting in at the post-surgical level or even afterwards, how insurance status will affect the outcomes of these patients. And then you have this kid at 13, 14, or 15 already has a poor outcome, and their die has already been cast in terms of what their health may be when you look at them 20, 30 years down the road. And now this is a great study, and I know this isn't replicated for every single pathology out there. So it's a great kind of like example of this is like data in, let's throw some garbage out there and then get a PubMed publication. But then no one ever talks about how we can change this. So this was a study where basically down at it was done by Skaggs down at LA, but one of the authors now at Cincinnati, where they basically just cold called offices and said, hey, I have a 14-year-old patient who has an ACL tear. And then they said, I have private insurance, then I have public insurance. And he found that when you said you had private insurance, 38 out of the 42 practices actually scheduled that patient. Whereas when you said you had public insurance, only 14% of the offices offered an appointment. Okay. So you can see at that level where the delay in care is occurring. Pediatric ACL, great reimbursement, but these facilities are not willing, just simply based on insurance status, willing to offer these patients appointments. And they've shown this in rotator cuff. They've shown this in other areas as well, too. So I think that's something important. We need to say, why aren't these practices offering this appointment? Have they actually looked at their reimbursement patterns? Have they worked with the hospital system to say, hey, I want to take care of these patients. I want to actually work with you in terms of how we can get reimbursed. And then that's that next level you can take, as opposed to just at that front office level where you're just refusing to take care of these patients and they're trying to navigate the system themselves. Krishna, who actually surprisingly did an ACL study with me, not just doing spine, and Abhinav, who's obviously here. We found this as well too in our population here in San Francisco, and we looked at our private and publicly insured patients, and what we found that even when you look at it where these treatment delays are occurring, we found that privately insured patients were able to actually get their MRI 50% faster after their injury. And we all know, particularly if you're in a pediatric sports clinic, you'll see a patient, you'll tell them to get an MRI, and then half of them disappear off into the sunset. You never see them back. And a lot of that has to do with how quickly they're actually able to get that MRI. So a privately insured patient gets that MRI within 3 days. They go into the whole publicly insured, kind of group. And then it can be 3, 4, 5, 6 weeks. They get one phone call. Their parents aren't at home. No one's picking up the phone, and then they never get their MRI. So the ability to quickly get in patients for that imaging diagnosis, because once we can diagnose them with their tear, it's easy to track them down, but then you never see them again, and it's hard to kind of capture them. So it's understanding how we can improve the authorization process. We also found that even getting them in afterwards, once they had a diagnosed ACL tear, was approximately 1 month shorter for privately insured patients. It's the authorization process, the ability to actually, for the surgery schedulers to contact them because their parents are typically working. So all these different factors playing the role in terms of why they're getting scheduled 5 to 6 months out of their injury. And then we have to figure out creative ways in terms of how we can bridge that gap, whether it means calling them in the evening, whether it means trying to get their MRI scheduled while they're still in the office, et cetera. There are ways that we can do that. And then this affects them downstream. They're more likely to have medial meniscus tears, they're more likely to have chondral injuries when you get that treatment delay. So it's important to understand how this impacts the patient. We see in the operating room, it'll be like, oh, their meniscus tear is really, really bad because they waited 5 months to get their surgery done. Was there something you could have done as a clinician to prevent that from occurring so that you're debriding a small meniscus tear as opposed to fixing a bucket handle tear and then saying, oh, well, the patient never came in for surgery. Well, why didn't they come in for surgery? It's important to look at those factors. And this trend holds true in adults as well too. Same sort of study where they basically just looked at public versus private insurance, not just even in kids, it happens with adults as well too. So it's not just a pediatric specific pathology, but a lot of the research has been done in terms of pediatric sports, in terms of delay to care. This also holds true in meniscus as well too. This was a massive database study that looked at 32,000 patients, adults and pediatrics, and they found that if you were female, and this goes back into, uh, you know, provider expectations of activity level and what treatments to offer. If you're a non-white and you had your public or self-pay, you had lower rates of meniscus surgery, and they controlled for the type of meniscus tear. So if you took someone who had a bucket handle meniscus tear, same tear on MRI, they would offer the female patients injections, non-operative treatment. If you're African American or Latino, you wouldn't get surgery in your public or self-pay, versus the privately insured patient who would suddenly be booked that next week to get a bucket handle meniscus tear fixed. So I think it's important to note that even the treatments that these patients are getting, which we don't report in the literature, vary based on these factors. And even if you look once again at the pediatric sports literature, which once again is important because having a meniscus tear at age 12 or 13 in general at baseline is bad for your adult health. Also, particularly since a lot of these kids re-tear, even when you look at access to care, when you look at pediatric and adolescent patients, public and uninsured patients experience treatment delays. And these treatment delays were a lot of times would take a tear that you typically would repair in a time frame and then made it irreparable because the meniscus didn't have good blood supply anymore. So it's definitely impacting care. And we've shown this again as well too in multiple studies as well, both in the adult population, even for tears that are as bad as bucket handle tears, we figured that the criteria should be the same. Uninsured patients have a greater time to surgery. Okay. We've seen this in rotator cuff as well too. Patients with the same factors have lower socioeconomic status. But the interesting thing about this study is you can imagine that if you have public insurance, you have less facilities to choose from. You potentially are going to lower volume surgeons. We know for things like rotator cuff, we know for things like arthroplasty, better outcomes come from higher volume surgeons. But if you have certain insurance plans, you have a subset of a subset of facilities you can go to. So if you're going to the public hospital in your area, or the hospital that's in, only a hospital that's in your community, and there's one person who does rotator cuff surgery once every 25 months, you're going to have poor outcomes. So it's important to understand also who they're accessing for care. And same sort of thing, just with rotator cuff, you're able to access care more quickly. And also when you call these facilities. So same sort of thing with rotator cuff. You have the same delays in care. You have it with shoulder instability as well too. It's harder to get into these patients with public, offices of public insurance. And a great example of how treatment delay leads to poor outcomes. Because I think in meniscus tears and ACL, sometimes it's hard to notice this. In shoulder instability, we know that the more dislocations you have, the more likely you're going to have bony lesions. And then to go from an arthroscopic Bankart procedure to a ladder J procedure, huge difference in terms of outcomes and morbidity. So do you know that shoulder instability patients who have public insurance are probably going to dislocate 8, 9, 10, 11 times before they get in, as opposed to the privately insured patient who may get in after their first or second dislocation. And a lot of this is multifactorial. It's also all the access issues, but you also have to think about the emergency room, what's going on there. A lot of times if you have a shoulder dislocation patient, they're told, look, wear a sling, go to your primary care physician in 2 to 3 weeks, and you'll be fine. Well, this happens 8, 9, 10, 11, or 12 times. And are we doing a good job of educating offices to know that, hey, shoulder instability is a problem? We want to make sure that they aren't getting bony procedures done as opposed to a soft tissue procedure. So that's where insurance status plays a role as well too. We looked at this well too with Nicole, who's applying for ortho right now, Nicole Hung, and we found the same sort of thing, that publicly insured pediatric patients had greater treatment delays in terms of time to clinic, time to MRI, and surgical outcomes. When we looked at my cohort of patients, 0% of the privately insured patients redislocated after labral repair. 25% of the patients with public insurance redislocated. Okay. And if we look at that group, the publicly insured patients had more bony lesions, they had less PT visits, and a lot of them just disappeared from care because they just simply didn't have access to the same sort of facilities as a privately insured patient had. So now we're trying to do things in terms of getting them physical therapy visits, whether it be by video or having group physical therapy or things like that, that can help ensure that they understand what the surgery is to help improve these outcomes. And this is at a safety net hospital at Children's Oakland, where we're seeing everyone regardless of insurance status. And we would think that there shouldn't be delays or disparities based of treatment based on that, but we need to take a closer look and look at why are these delays occurring. And you can see at every level you see treatment delays and the outcomes are affected as well too. It's also important to note that in sports medicine in particular, because there are multiple different providers who are providing care, it's the primary care physicians, it's the orthopedic surgeons, it's the physical therapists, the athletic trainers, et cetera, that there are multiple areas where this disparity occurs as well too. And if you look at data for athletic trainers, we know that athletic trainers are not necessarily at a lot of the public high schools in the area. And if you guys cover PlaySafe, that's one of the few programs that actually gets athletic trainers into public schools. But we do know that when pediatric and adolescent patients get an injury, if they have access to an athletic trainer, their outcomes are better, particularly for things like concussions, for things like traumatic knee injuries. Athletic trainers help to basically navigate the healthcare system and can diagnose something. Because you can imagine if you're playing, high school, high school football somewhere, in a non-COVID area, and you suffer an injury, your athletic trainer is the one who's going to basically be the one that says, "Hey, you need to go to the doctor. Hey, this is not something that's appropriate." If you have access to one, you're going to get into that office. If you don't have one, that's going to be a whole other issue. So that's even where things like athletic training and physical therapy play a role. But even in the athletic training room, the same issues in terms of bias and disparities exist. And this was a study that looked at NCAA, athletic trainers, and they found that even perceiving pain of an African American athlete versus a Caucasian athlete, there are differences in terms of the treatment rendered, even based on the same injury. So this trickles down at every single level. So I think it's important, not just in our offices, but for the total team that we're working with, particularly in sports medicine, if that's what you go into, that we're understanding how those disparities impact care at every single level, particularly with these injuries. And I think the last level where it kind of impacts, and this is from my Pete's perspective, is disparities in access to actual sports participation. Okay, so we think about how this impacts your ability to get treated when you actually have an injury in it itself. But I think for kids, access to sports participation is really, really important. And that then subsequently not only impacts their ability to rehab from their injuries, but their ability to actually be healthy. And if you look at the actual disparities right now, there's only about 5.5 million children when COVID, pre-COVID, who are involved in school sports, but 30 million children who are involved in out of school sports. Now you have to think about that is that, okay, well, there are more people playing club sports and things like physical education are dropping in schools. Where are groups of kids who necessarily don't have the money to play private sports or club sports actually getting their physical activity? Okay. So there's no PE classes, and PE classes are like Sachin's CrossFit class. You're working on core strengthening, you're working on all those things. You're getting those basic things there. So if you have a kid, their only options are, if they're not getting it at school, it's going to be number one, am I going to go to find some money to play at a private club where I'm just learning about skills and have all the injury risk of sports specialization, or am I just not going to play sports? And then you're subsequently going to have a kid who's at 13 who doesn't have an outlet for sports but still can't afford it. That's a huge disparity in terms of how it affects health outcomes, because a 13-year-old deciding to retire from sports because they don't have access to it is going to lead to them have metabolic syndrome, where you're going to get the type 2 diabetic at age 18, 19, or 20. So I think it's important for us as providers to help dispel this, not necessarily from an injury perspective, but to keep kids healthy and active. So we have this dichotomy right now, and this is even getting heightened with COVID, because now the only sports that are really taking place are the club sports. Is you have one group of kids who are playing club sports and have all the risks of injury that could be a whole nother talk, and then you have a whole other group of kids who have no access to sports and are getting obese. So I think it's important to understand that. How can we improve access to sports participation and also healthy sports participation as well too? In a sense, what's happening is that we know the kids are specializing and they're playing one sport, and that leads to the injury risk. But the outgrowth of that specialization movement is that a whole group of kids don't have access to sports. And I think that's important to note. Just like with everything else we talked about disparity earlier, we concentrate on how specialization leads to injuries, it leads to ACL tears, it leads to all these things. But we don't talk about how specialization leaves this whole group of kids excluded from sports, and kids just aren't playing sports anymore if they belong to a certain ethnic group or they belong to a certain socioeconomic status. So I think that's important to recognize. And a lot of this has to do with the money that's tied into it. If you actually look at how much money youth sports is involved, and this actually was $18 billion the year before COVID. I mean, that's a tremendous amount of money that goes into it. And for a lot of parents, it then becomes very expensive. And you look at the actual data, 63% of parents will pay between $100 to $500 per month, with 20,000 paying upwards of $12,000 a year. I mean, that's a tremendous amount of money. Now you can imagine if you are at the lower, if you're from a household that has a lower income, I mean, paying $10,000 to $12,000 a year for sports is a ridiculous amount of money. So then you say, well, I can't afford to participate in sports. Then you have to look at what community offerings are there. And for many of us, we may have done school-based sports or involved in, kind of rec center sports. They just aren't out there anymore. I mean, even community-based sports centers will have $200-300 fees. So where are these kids going to play? They're not getting it at school. They're not going to be able to get it in their communities, and their parents can't afford it. So what do? They retire from sports at age 12 because there aren't those options over there. And another interesting fact, which is, which, kind of lends itself to how we need to change this culture. You imagine $12,000 a year at age 10 for sports. The cost per year is more than the average scholarship amount. So if you look at NCAA data, the average scholarship award is about $11,000 per year. Okay. And that's only 2% of all high school athletes will actually get a college scholarship. And there are only 6 sports that actually will give you a full ride. And 2 of the sports, which we constantly kind of, associate with year-round sports, are baseball and women's soccer. They don't get full rides. So a lot of these kids are going to be playing sports year round, will never actually get a full ride, and are actually going to spend more money per year in terms of club sports than they'll ever get in terms of a scholarship. And the outgrowth of that is not only are these families wasting money and they're, basically incurring increased injury risk, they're basically excluding these whole group of kids who can't play sports because they've created this financial barrier to access to play. And it doesn't account for the injuries that these families incur from expenses, which strains the healthcare system as well too. I think a great article that I encourage you all to read, which kind of really ties this all together, is this article on the Undefeated. It's a sports a sports media article. They looked at the gentrification of college hoops, and I think this really brings home the point of what we're looking at, is that we've basically excluded a whole bunch of kids from playing sports. And the whole thought, at least in my mind, of what a scholarship is supposed to do is to give opportunities for students who may be from lower income households or from historically disenfranchised communities. And scholarships should technically be a way that these kids can get out of the situation they may be in. But if you actually look at, and this was a study looking at NBA, college basketball scholarships, we found that college athletic scholarships are more likely to go to students who are higher socioeconomic status than the average student, less likely to be first generation college students. It's the antithesis of what you actually thought. That actually scholarships should be going to. And then why is this happening? Well, you can imagine how the youth sports complex is right now. Number one is that you have to pay to play. And the only place where college, coaches are going to look for scholarships are these showcases. So essentially your ability to actually get a scholarship is predicated on your income. And in fact, there's some studies now that show the more money your family has, the more likely you're going to get a scholarship, because you're going to be able to go to these showcases. You can travel around the country. And you have whole groups of kids who are left out now because they don't have opportunities to play, then can't get that scholarship. So from a larger societal standpoint, these disparities in youth sports participation are not only having issues in terms of their injury risk, it's their ability to play, and then subsequently then impacts their ability to get to college because they don't have the same resources as other students. So I think it's important to note how this very kind of specific sports medicine topic in terms of pediatric sports then trickles down in terms of affecting these kids for the next 20, 30, 40 years of their life, simply because there are barriers in terms of participating and disparities that arise because of this. And lastly, right here, the Aspen Institute's done great study looking at this and find that if you make under $25,000 a year, only a third of these kids will play sports, whereas over families that make over $100,000 a year, 70% of them are able to participate. And Robert Wood Johnson looked at this as well too. Only a quarter of middle and high school students from lower income areas participate in sports. So once again, we need to keep our kids healthy and active. And we think about disparities in terms of accessing medical care, disparities in them even being healthy and active. And as much as we like to take a 12-year-old and tell them to go out and run or ride your bike or things like that, they need access to team sports. I mean, that's where they're going to build their community. They're going to improve their mental health, and they just don't have access to that. And that, I feel, is perhaps more of an issue in terms of how we treat pediatric sports patients than necessarily the technique that we use for ACLs or how we treat their discoid meniscus. So I think in conclusion, how can you help? I think that's the important thing. What are tangible things that you can do as a provider, both from an orthopedic standpoint and from a sports medicine standpoint? And even if you try to do one or two of these things in your practice, I think you can help break these disparities and kind of help how we're doing. So number one, I think you have to, first of all, recognize that disparities exist. And I think pretty much everyone here knows that. We have programming, we're choosing residents and students here who understand that stuff, and recognizing disparities exist. But if you don't, I think it's important to get a sense of that. Number two, I think it's important, even at the resident level, to provide care that is patient-centered and culturally competent. So I think, you don't have to go in there and check it off in a list every time you're in there, like you're writing a note. But in general, just understand the effect of factors such as race, sex, socioeconomic, insurance status on access to care and outcomes, and try to take that into consideration when you're devising treatment plans for these patients. The American Medical Association has this health disparities toolkit that basically allows you to recognize your own knowledge assumptions, look for your blind spots. You can see, oh wait, I never thought that this was the way that I was, thinking about care received. So that may be, I didn't think about gender. Maybe I didn't think about, how rural coming from a rural area impacts their care. So just look at what your blind spots are. I think it's important, particularly if you get to as a senior resident level, or if you're an attending, or even if you're a junior resident, train your staff and fellow physicians in your group about cultural competency. Just let them know it, make it part of your daily conversation so they can understand that and become something that's second nature, as opposed to something that's very like prescriptive or something that you feel like you're doing almost artificially. Another part which I didn't talk about as well, but I think is important, is that ensure that language isn't a barrier. So often we go into rooms and we're just not willing to take the time to find an interpreter, or we depend on the 7-year-old who's on their iPad to interpret for their family. That's horrible. I mean, if you were, imagine, place yourself in a situation where if you were a patient and you're a trauma patient, you're on vacation, non-English speaking company, and you're depending, if you have kids, on your 4-year-old to translate to the physician what they're going to do. It's just not appropriate care. So take that extra time to find an interpreter, particularly if you're not facile in that language. I think the other part is make sure you provide patient education materials that account for different ethnic, racial, socioeconomic perspectives. So I think the most pressing way is when you look at post-operative instructions after surgery, like fracture care, things like that. Sometimes it's a little bit easier, like keep your cast on. But for something like sports medicine, where there's very specific instructions, like when you take your dressing off, how do you put your brace off and on, when you start your CPM machine, when you start motion exercises. If you just give a patient, when they're coming out of anesthesia, these whole bunch of instructions in English, but you don't have them involved in other languages, or you don't provide an interpreter in the post-operative care unit, that's going to lead to them having poor outcomes. And the number of times I'll have a patient come in who, may not have necessarily had it, or, the nurses in the PACU may have said, oh, we did it. And they come in, they have no idea what the brace is, what was done. We need to improve that ability for that material that they get when they leave the hospital to be in their language, or basically to have it translated to them, is really, really important. Try to volunteer in initiatives that basically improve diversity. I know a lot of us are involved in the diversity committee here in UCSF, but looking at from different areas, whether it be the Gladden Society, the Jackson Society, by volunteering in these initiatives, I think it's important that can advocate for diversity in our field, because as we talked about, that's obviously something that needs to be worked on. When you go out into practice, make a commitment to see patients who are publicly insured or have Medicaid, and that can be, sometimes you have to push. You have to, push with your practice administrator. No, I want to see these patients, or you work with the hospital figuring out reimbursement to get these patients in. Work with the primary care providers or community health organizations to help facilitate these patients getting in. So helping them be like, look, this is the number you call to get a referral in, or this is how I can see this patient, or call me directly because they're getting lost in a work queue. Talk to the primary care providers, talk to the people at the community health clinics, and figure out what their barriers are to getting their patients in, so that you can improve access to care. And then I think it's important to look at your own practice, collect data on race, ethnicity, and payer mix. Report that data when you're doing your research studies. So if you are all involved with attendings on doing research projects and you're like looking at outcomes, hey, look at this in terms of race, look at them in terms of payer mix, look at them, report that data, because a lot of times the outcomes that you may be seeing, if you stratify them based on those characteristics, you're going to see different things because it's not necessarily reported in an appropriate fashion. And from a global perspective, as you all go into your communities, some of you may have children who are playing sports or will have children, make sure that in your communities that finances aren't a barrier. So that means working with your schools, if your kids go to public school, to make sure that sports are accessible, making sure the community-based programs are available for your kids. Because if you can do that, then you can get more kids healthy and active, which is important for their long-term health. So thank you. I know that was not necessarily your very, usual hardcore kind of like this is how you do an ACL reconstructive talk, but I think it's important just kind of keep those factors in mind and know how it affects our pediatric population. So if y'all have some questions, I'm ready to take them on for you. So.